under the breast requires the surgeon to go through less than a ½ inch of normal tissue, compared to an inch or more for axillary and periareolar incisions and 10 to 12 inches of normal tissue for the belly button incision. All implants must pass through a tunnel of tissue as the surgeon introduces the implant into the pocket. The longer the tunnel, or the more tissues the implant contacts on the way into the pocket, the more the implant is exposed to areas that might contain bacteria. Those bacteria contact the implant and increase risk of infection or capsular contracture. Again, the inframammary incision under the breast has the shortest tunnel with the implant contacting the least tissues, with axillary second and periareolar and umbilical approaches a distant third. The periareolar approach requires a tunnel through portions of the breast tissue that are known to normally contain bacteria and that might increase risks of capsular contracture or infection, though neither has been proved to occur more with periareolar incisions. Which incision locations had the most nuisances associated with them after surgery? Whenever a surgeon makes an incision, the surgeon cuts nerves to the skin area and numbness occurs following surgery. Small bands of scar tissue can form or small collections of fluid may accumulate. These nuisances are less noticeable for most patients in the inframammary area under the breast compared to any other area. The bottom line, if you want the most control for your surgeon with the least injury to normal tissue, choose the inframammary approach. If for any reason you think that you might focus more on a scar under the breast instead of a marked improvement in the breast appearance, choose the axillary approach to move the scar off the breast and accept the trade-offs. If you simply want the periareolar or umbilical approaches because you know someone who has had them and like them, be sure that you understand the potential trade-offs and select one of them. Finally, you should be aware that if you develop any type of problem that requires additional surgery, for optimal control of most problems, an inframammary incision is required in virtually all reoperation cases. If you choose an incision other than inframammary and require additional surgery in the future, you should be aware that your surgeon may need to make an inframammary incision. On your paper-informed consent document, carefully read item 14 and choose only one of the 5 choices. When you have completed this portion of the program, please press the forward button on your DVD player to continue to the next topic. Your breast implants can be placed either behind breast tissue only in a retromammary pocket or behind breast tissue and partially behind your pectoral muscle in a partial retropectoral pocket. Choice of pocket location should focus on assuring that you have adequate thickness of tissue covering your implant and on minimizing risks of capsular contracture. Let's consider each of these topics separately. One of the major causes of long-term problems in breast augmentation is placing an implant under inadequate tissue cover, tissues that are too thin covering the implant. If you choose to place an implant in front of the muscle and you are thin, or if you choose an implant that is too large and causes stretch, further thinning of your tissues, you will feel and may be able to see implant edges, regardless of the type of implant. In addition to seeing or feeling implant edges, implants under thin tissue cover are more likely to develop visible wrinkling or rippling in various areas of the breast. In the past, some surgeons have preferred placing implants in front of the muscle to minimize the trade-offs of placing implants partially under the muscle, trade-offs that you can review on card 23 in the Best Breast book. Newer surgical techniques have not only drastically reduced all of the trade-offs listed for under-muscle placement, but have also dramatically changed recovery. Today in our practice, there is no difference in recovery for patients having had implants over the muscle versus under the muscle, and over 95% of both groups can return to full, normal activity within 24 hours of their augmentation. Placing implants partially under the pectoralis muscle has 3 important advantages. 1, providing thicker soft tissue cover over the upper portion of your implants. 2, it may improve accuracy of your mammograms in the future. And 3, potentially reducing risk of capsular contracture, especially with silicone gel-filled implants. How your surgeon creates the pocket for the implant is critically important to how much bleeding and tissue trauma will occur, how long your recovery will be, and how many risks of problems you may have. Older methods of pocket dissection include blunt dissection using a blunt instrument or the finger. These methods tear tissue and always cause more bleeding and tissue trauma compared to more precise electrocautery dissection